So bacterial endocarditis, the valves have poor blood supply and they're higher risk if they're structurally abnormal. Other risks include prosthetic valves and intravenous drug abuse. Patients with indwelling lines, such as patients on TPN, chemotherapy with indwelling sources of infection, and being over 50 years old is also a risk factor of having bacterial endocarditis. But in 50% of patients, no underlying cause is ever found, and it's a real diagnostic conundrum sometimes, and it's often pyrexial of unknown origin will turn out being a bacterial endocarditis, which is why one of the workups for it will be an echocardiogram. So the symptoms can be remembered from Jane. That's fever, and you'll get that in 95% of patients. Then Roth spots, and Roth spots are rarely seen clinically, but they're round white spots on the retina surrounded by hemorrhages. Osler nodes are painful nodes on the fingers and the toe pads. New onset murmur, which is usually going to be mitral in etiology, but any new onset murmur is still in the criteria. Janeway lesions, which are similar to Osler nodes but are non-tender. And then anemia associated with chronic disease. Nail bed hemorrhages or splinter hemorrhages. You might also see clubbing in this patient. And then embolite anything that causes turbulent blood flow can cause hypercoagulability of state. Other things you might see would be splenomegaly, and also they can develop glomerulonephritis, and with this glomerulonephritis, it's not uncommon to have hematuria with that. So acute versus subacute. So this is a little bit dated, but I think still used. You have the acute, gives you a staph aureus usually, and this patient's acutely unwell. And these are the ones that you have a tendency to worry about. They're quite easy to diagnose as they come in. They previously have normal valves, but it's a rapid onset illness, as opposed to the subacute, which is usually Streptococcus viridans, and they have abnormal valves, be it a bicuspid valve or a prosthetic valve, or a previously injured valve secondary to myocardial infarct or to rheumatic valvular disease. For completeness sake, Liebman-Sachs here is not in either of these subgroups, but it's a sterile vegetation. It's usually second through lupus, and it usually affects the mitral valve, causing mitral regurg, as opposed to mitral stenosis, and it's usually a benign, self-limiting thing. Once you treat the underlying cause, it has a tendency to improve. So the pathogens associated with it, Staph aureus is by far the most common. In prosthetic valves, coag-negative staph and staph epidermis can also be found, and that's obviously when you've got a prosthetic valve. Obviously, it doesn't have the normal immune systems that you would expect. In IVDU, Staph aureus is still common, as is the skin on the skin, as is epidermis. Pseudomonas is a difficult one to treat, as is Candida, but Pseudomonas associated with patients who have no fixed abode in IVDU with chest infections can develop Pseudomonas. And in the elderly and patients with colon cancer, strep bovis, which I've not seen before but comes up. Other pathogens that are special because they are culture negative and cause endocarditis is this group: Haemophilus, Acintobacillus, Cardiobacterium hominis, Ichinella, and Kinganella are a group of weird and wonderful ones that I've not seen clinically, but the purposes of EMQs are probably good staple common fodder, and unfortunately you probably just have to remember those. Diagnostic criteria is done through the Duke's criteria, which has been modified. There's some majors and some minors. There's two majors, and that's blood cultures. If you have blood cultures with a known pathogen that causes bacterial endocarditis, then that's a pretty good bet. You need blood cultures from two different sites at two different times, and then you get endocardial involvement on an echo. So just remember, bacterial endocarditis means it's the endocardial is involved, and that's the most intimate part of the, so from going from out to in is the pericardium, the myocardium, and the endocardial. So the endocardial is the most inner part of the heart, and it covers all of the heart, including the valves, and that's why it commonly causes vegetations on the valve because it's that. But if you do an echo, you can either do transesophageal echo is gold standard, so down the esophagus, which gives you good views of the left atrium, and with that the mitral valve and aortic valve will get better views through a transesophageal echo. And then the minors are mainly made from the Janes, so the fever, Roth spots, Oslo nodes, murmur, Janeway lesions, anemia, nail bed hemorrhages, emboli, splenomegaly, and signs of glomerulonephritis. And if a patient's also high risk, so if they are have IVDU or prosthetic valve, or have an indwelling catheter, or venous catheter, then poor dentition, then this is a patient that you think could be at higher risk, and then they also get one from the minor. So you need 5 minors, or it's a bit like a driving test, or you need 2 majors, or 1 major and a bunch of minors. We'll do that. So once you've made your diagnosis, it's time to move on to treating someone. And the treatment depends on what you find, but the penicillin and gentamicin can be the treatment, but in Staph aureus, a lot of Staph aureus is resistant to penicillin, so probably first line now would be vancomycin plus gentamicin. And the two used together have a synergistic effect and have quite good penetrance in clearing this pathogen. You need a prolonged course to clear, and obviously if you have blood culture positive to something weird and wonderful, or something not sensitive to vanc or penicillin and gen, then you'll need to consult microbiologists and treat accordingly. But for the most part, I think vancomycin and gentamicin would cover most things. It's important to treat for until you've confirmed that you've cleared it, and complications can arise, such as chordae rupture, which will obviously give you mitral valve prolapse. The chordae, remember, are like the parachute cords which hold the valves, which you think of as being like parachutes in the valves. Then also they can develop quite bad glomerulonephritis and pericarditis, and you need to also watch out for the emboli phenomenon. But currently, emboli prophylaxis is not indicated in the treatment of bacterial endocarditis.